Hi everyone, it's a pleasure to welcome you all to this IFORIAS webinar. Today, we'll be focusing on the evaluation of HER2-low and ultra-low status in advanced breast carcinomas. My name is Ruth Pedrosa, and I'm a Senior Field Application Scientist at IFORIA Technologies. I'm delighted to be joined today by Dr. Aniko Kovac, who will share her expertise during this session. Before we narrow our focus to HER2, I'd like to start with a brief introduction to IFORIA and our solutions. IFORIA is a medical software company founded about 12 years ago. We provide pathologists and scientists with powerful cloud-based deep learning and AI technology. Our team brings together pathologists, scientists, software developers, and a dedicated commercial team. Today, IFORIA supports over 5,000 users in more than 50 countries all over the world. Our headquarters are in Helsinki, Finland, with subsidiaries in the United States and France. At the heart of everything we do is our mission: to transform pathology image analysis with AI, enabling better care for every patient. IFORIA's portfolio spans the full journey from research to clinical practice. IFORIA Clinical Suites deliver complete, case-centric workflows designed to enhance efficiency, consistency, and diagnostic accuracy in pathology labs. We currently offer the broadest portfolio of CE-IVD-marked AI models for diagnostic support. Our research solutions provide fully automated, study-centric workflows and image analysis applications suitable for all research domains, with full compliance to GLP standards. And finally, IFORIA Create. Our flexible AI development platform empowers users to design, train, and validate their own AI models, and even translate them into clinical use. This is the very tool Dr. Kovac and her team used during their project. Here you can see in more detail the breadth of IFORIA clinical suites, which span the entire workflow in pathology, from sample analysis to diagnosis. On top of the screen, you can find our lung cancer suite, which supports the PDL scoring. Going further clockwise, on your right side, you can find one of our newest additions, the lymph node metastasis detection model, which identifies metastases from 3 different primary cancers. Underneath, we have our gastric suite, which enables detection of gastric cancer and H. pylori detection. Down below, the prostate cancer suite includes Gleason grading, as well as detection of adverse findings like perineural invasion, or most commonly known as PNI, high-grade PIN, and cribiform pattern. The colon suite currently offers a prognostic model for predicting colorectal cancer recurrence. And last but not least, our breast cancer suites includes H&E-based cancer grading and a complete immunohistochemistry panel, including ER, PR, Ki67, and HER2, which will be the focus of today's session. Now, it is my pleasure to hand things over to Dr. Aniko Kovac. Dr. Aniko Kovac is an associate professor, pathologist, and lecturer at Sahlgrenska University Hospital. She has more than 23 years of research experience in Sweden and previously conducted breast cancer research at Leicester University in the UK. Her extensive background also includes research collaborations in Japan and Hungary. Without further delay, Dr. Kovac, the floor is yours.
I greet everyone from Sweden, from the second largest city, from Gothenburg University. And actually, this scenario reminds me the Eurovision Song Contest, when they are saying at the end from each country, and now Sweden is calling. I would like to share my experience about HER2-low and ultra-low assessment with you. But first, a short clinical and pathology background. So in January 2023, ENHERTU had been approved in the European Union as first HER2-directed therapy for those patients with HER2 low status who already developed a distant metastasis. So according to Destiny Breast 04 study, Enhertu reduced the risk of disease progression by 50%, and it was also eligible for those patients as monotherapy who had unresectable breast carcinomas or developed progression during the metastatic setting. So how should we measure, we pathologists, the HER2 status in these tumors and determine who will benefit most from the trastuzumab deruxtecan therapy? So those patients who show by HER2 immunohistochemistry 1+ or HER2 non-amplified, they classify as HER2 low. Just a short reminder, when we evaluate HER2 immunohistochemistry, we are scoring. So score 3+, it is a strong circumferential membranous staining, and very often you can see it in the entire tumor area. When you have a score 2+, there is a circumferential staining, but intensity is weak or moderate, so you need a confirming in situ hybridization. 1+, it is only a partial membrane staining in at least 10% of tumor cells. Score 0, no staining, or only 1+, but in less than 10% of the tumor cells. So up to 2023, we had a dichotomized answer alternative. Either we said HER2 positive amplified and the patient received a HER2 blockade, or we said HER2 negative non-amplified. But that time, another concept came into the picture, 1+ and 2+ non-amplified. So we had to push on the reset button when evaluating HER2, because when you are looking at the whole HER2 spectrum from total negative to HER2 amplified, in between there is the HER2 low group. It is very important to assess this HER2 low status because there is HER2 expression changes in the metastatic setting, which means when you evaluate the surgical specimen, there can be another HER2 status in the distant metastasis. And nowadays, there is no molecular assays available to confirm if this particular tumor belongs to HER2 low category. There are challenges in immunohistochemical scoring because there are different antibodies in use, which are stained on different platforms, and there are different scoring systems. And I would like to underline that majority of pathologists are still using conventional microscopy versus, like we here in Gothenburg, we evaluate HER2 digitally on scanned slides. And even there is a smaller group pathologists who have access to artificial intelligence. It is important to know that there is spatial and temporal heterogeneity in primary tumor versus metastasis. I summarized here the antibody used in Sweden. Mostly it is the Ventanas 4B5. And after that comes the Dacos Hercept test. As a long tradition, we are using the Dacos Hercept test. I show this publication is a comparison study when Hercept test and Ventanas 4B5 antibodies were compared, and you see that 4B5 antibody identified at least 3 times more HER2 low cases, so it showed a higher sensitivity. Most recently came out this publication now in July, showing the same scenario. So Dacos polyclonal antibody versus Ventanas 4B5. So look at this group with 0. So more than half was upgraded by 4B5 to ultra low or HER2 low category. But on the contrary, when using a Hercept test monoclonal antibody, then showed higher sensitivity in comparison with the 4B5. So you can see that there is quite a variety among these antibodies. So what kind of difficulties do we face when we evaluate immunohistochemistry? So distinguishing score 0 from score 1+ is not pursued in the daily practice because previously we were not focusing on that. But definition 1+ score is not univocal. And it may happen that there is 2+ with intense membrane staining but incomplete membrane staining in less than 10% of the positive cells. On that histological picture, I show you a very rare HER2 status when you can see a very sharp demarcation zone between very positive 3+ area, and on the right side, it is only score 0 or score 1+. So the tumor heterogeneity, which is much more common for 1+ and 2+, may lead to poor consistency when we interpret HER2. In the ASCO-COP guidelines, you may find only description for HER2 genetic heterogeneity. So there is lack of consensus about determining HER2 heterogeneity in immunohistochemistry, because there can be uneven distribution of the different scores, expressions, and with different intensities. I am just showing this painting. Is it an artwork in the style of Victor Vasarely? So this picture depicts a clear form of imaginary visual representation of what we are working with every day. So here are not so many tiles, but I ask you as a visual estimation, how many of them in percent are black, gray, or white? I don't know if my arrow is seen, but for example, this one, is it gray or black? The same question here, or here are 5 tiles. Which of them are clearly white or grayish? I did it by myself, so it was eyeballing on the screen. So I counted one by one, and I concluded that 42% of the tiles were black, 46% gray, and only 12% white. But actually, it was a subjective assessment, and if I should repeat now, I am very, very certain that these percentage would be different. We are having the same scenario when we should eyeballing a HER2 Hercept test staining. So no wonder that these authors concluded that there is high intra and inter-observer variation in HER2 low assessment. So what is the solution? It should be an adequate evaluation. And it is artificial intelligence who can give us a quantitative evaluation. Moreover, if you are marking an area, you are counting by AI, and if you are marking that area tomorrow or the day after tomorrow, it will give the same percentage, the same scoring. So in that case, scoring results are reproducible, and it is very important for us. Another study compared pathologist eyeballing in the microscope versus artificial intelligence, not only in the primary tumor, but even in their distant metastasis. The different scores were decorated by different colors, and you can see the obvious discrepancy. But there is even an undergroup, HER2 ultra low. So those tumors who show 1+ score, but in less than 10% of tumor cells belong to this group. So there are even further ongoing studies like, do outright negative HER2 null tumors respond to this therapy? And the answer was yes, up to 30%. So we have quite important question. we should choose that which patient will benefit from this therapy. But I would like to call your attention that all these findings, both in the DESTINY 04 and 06 studies, were based on evaluations using conventional microscopy. So when we designed our study, we decided to use Eiforia's AI assessment because it gives us an exact percentage for each score. We published our study more recently in July, and first I would like to show you our disclosure. So we elected 47 patients, all of them developed distant metastases, and they were diagnosed and treated between 2013 and 23. So before the era of HER2-low concept. We had two aims. One aim from the pathology aspect. Which assessment method, so which modality, conventional microscopy, digital pathology, or AI model, which gives the most reliable assessment? A question from the oncology aspect. Whom to treat? I mean, which time point, the surgical specimen or the distant metastasis? You can multiply this number, 47 patients, by 9 because we evaluated their 3 time points, so the diagnostic core biopsies, their matching operation specimens, and their distant metastases, which were identified in the liver, lung, bone, and brain. And each stage were evaluated by these 3 modalities. We analyzed 47 patients in 3 time points, and 10 of them received neoadjuvant chemotherapy, but all of them received adjuvant treatment after surgery. So we were interested in examining how HER2 status differed between the surgical specimen and the matching distant metastasis. 10 patients of the 47 had a triple negative breast carcinoma, and 10 patients received neoadjuvant chemotherapy. 4 of them belong to the group triple negative breast cancer. We retrieved from our archival the original Hercept test slides, not restained, but we re-evaluated, because those 6 pathologists who originally assessed the Hercept test, they were not using the HER2-low concept. It was before 2023. So we revised the scores on full-phased slides and the digital images according to the new concept. We used a 3-tiered classification, so score 2 plus 1 plus and 0. Before the study, 3 board-certified pathologists who were subspecialized in breast pathology validated the AI method. So our categories: HER2-low, those tumors who were 2 plus non-amplified or showed 1 plus 1 in over 10% of tumor cells. Ultra-low, score 1 plus between 1 to 10%. And in our category, how we called HER2 null, in this group were tumors totally score 0 or 1 plus in less than 1% of the tumor cells with difficult to interpret minimal membranous-like stainings. So for example, here, there is a very faint and very thin membrane staining, but somewhere even there are neighboring cells with cytoplasmic discoloration. So in this group, when we had 1 plus, we had difficulties to interpret. It is just a snapshot from our Excel table. So for example, some cases, the breast surgical specimen cases, we were working like that. So the first column, it is the original Hercept test value. If we needed to perform SISH test, and then the revised microscopy, revised eyeballing on the screen, and Eiforia's percentage. In each field, the sum of percent numbers are up to 100. So when using AI, we chose the I4IAs, and the HER2-low model was developed utilizing whole slide images on a cloud-based supervised deep learning AI platform. And it was trained, so a set of individual convolutional neural networks, so-called layers, were involved. So first layer, it is the total breast tissue, because we used the whole image on the slide. The next step, and AI was capable to delineate the invasive tumor, and after that followed the different scores. So it looks like this one, an invasive tumor showing 1+ and 2+, and even score 0. So we got a certain number of how many cells were counted, and with the matching percent. And even, which is of help, it is very demonstrative, that the different scores are shown by different colors. So the invasive tumor, the AI identifies the invasive part, and after that gives score for each cell. According to this assessment method, there was no problem identifying HER2 ultra-low. You can see here an invasive lobular carcinoma of classical type. So 1+ was found in 4.83% of the tumor cells. So it was very easy to categorize into HER2-low group. So each cell in the invasive part got a score with different colors. Our biostatistician analyzed and prepared for us Sankey diagrams, coefficients, and plots. So the first comparison, HER2-low status assessed in 3 time points, and each time point by 3 modalities. It is very interesting that in the core biopsies and in the distant metastases, we got the most cases in HER2-low category. It is interesting because both core biopsy and distant metastases represent only a tiny random piece from the whole tumor area. We did not see any edge artifact. But I would like to analyze one by one. So we had 5 discrepant cases in the core needle biopsies, and it was always the digital image and the AI which resulted in a higher category. We had 10 discordant cases in the surgical specimen group. And look here, for example, it was HER2 null in the microscope, HER2 null on the digital eyeballing, but AI categorized up. There were 2 such cases, and it was never vice versa. So always the digital image and the AI, which resulted in a higher category. And discordant cases in the distant metastasis, the same scenario, always the artificial intelligence or the digital image estimation, which gave a higher HER2 group. I would like to show you, for example, our HER2 null category, when in less than 1% of the cases, we had cells which were difficult to interpret, showing only a minimal membranous-like staining. So in the microscope, it was totally null or less than 1%, but on the screen and by AI, it was upgraded. It was in the group of surgical specimen and the same in the distant metastasis. There was no discrepancy in the core biopsy category. I had a very interesting request from one of the reviewers when we submitted our manuscript. So he or she requested that we should have taken pictures by camera on top of the microscope, showing that digitally the HER2 membrane staining is stronger than what we see in the microscope. So I chose 2 core biopsy cases, 2 surgical specimens, and 2 distant metastases. However, I answered to this reviewer that the microscope camera is connected to a PC. So slides which were taken in the microscope, they were converted to digital images. So therefore, these pictures taken through the microscope are not so different from those pictures which I took from the digital image. And I highlighted even that nowadays in 2025, I am not able to take a picture from my retina or from my visual cortex. So what we are using, making a picture in the microscope, it is already a digital image. So therefore, I did not include this comparison to the manuscript. So assessment of HER2 low status by the 3 modalities. I take it one by one. So comparing using conventional microscopy, the original core biopsy, the matching operation specimen, and the distant metastasis. So both in the core biopsy and in the distant metastasis, we identified 72% HER2 low cases using only the conventional microscopy. And you see here in the surgical specimen, this number was lower. Comparison, the 3 time points by digital eyeballing. So more surgical specimen and distant metastases were classified as ultra low, and none of the core biopsy samples were HER2 null. More HER2 low cases were identified by digital visual evaluation in general compared to the previous slide to conventional microscopy. And the last one, comparing the 3 time points by AI. So the number of ultra low cases was the highest in the surgical specimen, followed by the distant metastasis. And number of distant metastasis samples with HER2 low status was with 25% higher than the surgical specimen. So our results, the AI model identified more HER2 low and HER2 ultra low cases. The HER2 low expression differed between specimen types, and digital pathology showed stronger membranous staining. We had a question from our oncologist. Imagine there is a patient with a distant metastasis, for example, in the brain, and that kind of metastasis is very difficult to biopsy. So is biopsy from distant metastasis needed to confirm the HER2 low or ultra low status? Not already, because with all 3 methods, it was more common for HER2 expression in the metastasis to be higher compared to the surgical specimen. We show that here. So when we compare the distant metastasis with the matching operation specimen, in 83%, it was the equal category or it was a higher category. So conclusion for the pathologist, score 1+ and 2+ are mostly heterogeneously distributed, and it posed difficulty to assess when these cells were near to the cutoff point, 10% or 1%. Aiforia provided pinpointed individual findings, and we had stronger membranous staining on the screen. Conclusions for the pathologist are only questions. So which modality will be the golden standard? Which antibody is the most reliable? And which time point is the most reliable? To answer all these questions, further clinical studies on larger patient number are needed. So should we redefine the surrogate subtypes? Because in 3 of 5, there is a HER2 negative part. So should we extend it with a luminal HER2 low under subgroup or even triple negative subgroup? The final conclusion, these findings emphasize the need for a standardized HER2 assessment. As a closing accord, I would like to show you those milestones we experienced in pathology. So first, some decades ago, introduction of immunohistochemistry, and after that start with molecular biology. It was 2019 when we started using the digital pathology, and 2 years ago, we started using artificial intelligence to assess Ki-67 as a global score. I am very curious what will be step 5. Will it be an automated pathology? So our role as pathologists, it was a consultant in a breast cancer management in the 90s. But now we are participating in all these steps. So nowadays we are not only pathologists, so we can have maybe another name, diagnostic oncologist. Thank you very much for your participation.
Thanks again. That was a very insightful presentation of HER2-low assessment. So now we are back and it's time to our Q&A session. Please feel free to send your questions using the Q&A button. If you haven't done so already, of course, some questions have already came in, and I also have a list of questions that were sent prior to the webinar. So I'll probably start with those, and I'll give you a little bit more time to send all your questions in. We will do our best to answer as many questions as possible within the time that we have left. While we wait for your questions to come in, let's start then with the questions that I have here already in front of me. So to start with, the first question is, Aniko, is your daily pathology practice, in your daily pathology practice, how do you evaluate HER2 status? Under the microscope, digitally, or using a combined approach?
We are using a combined approach. So we are mainly using digital pathology, so eyeballing on the screen, but because it gives a stronger image compared to the microscope. Sometimes we even check in the microscope, but it is the digital scoring which decides if we should, for example, go further to in situ hybridization. So we are working digitally, but still we don't have access to AI evaluation. It will come from the 1st of January.
Very good, thank you. Our second question says, which HER2 antibody are you currently using, and which antibody was used during your study?
Yes, we were using Herceptin polyclonal antibody in that 10-year period. But last year, we switched to the monoclonal Dako Herceptin antibody. It was last spring.
Very well. So our third question will be, how is it with your oncologists? Do they request HER2-low evaluation on the original surgical specimen or on distant metastasis?
Sometimes on both. Of course, if distant metastasis biopsy is not available, we should re-evaluate the original surgical specimen, HER2 immunohistochemistry. But if there is biopsy from liver or lung, we are evaluating it from this HER2 low aspect. But very often we compare with the original in the surgical specimen.
Thank you. One last question before I start with the list of questions that we are getting from our public. This question will be then, is it common to find a different HER2 evaluation in the metastasis than in primary tumor? And which of the results will you consider for treatment purposes?
Yes, actually, it is quite a wide range. Most often, the distant metastasis shows higher category, but it can be even vice versa. So according to those publications we found in the PubMed, this discrepancy is between 25 up to 50%, which are quite high numbers.
Very well. Do you want to add anything else?
No, simply I wonder when there is distant metastasis identified several years later than we have started this HER2 low concept, I am very curious how the original HER2 evaluation was in the surgical specimen before the era of HER2 low concept.
Very good. I could continue this conversation, but we have a whole list of questions, so I will just start asking the questions from the people who are viewing us. Okay, so the first question will be, does HER2 low assessment need to be performed on metastasis, and are fresh biopsies mandatory?
Actually, we very often get biopsies from distant metastasis, even from the brain. So for us, it is not a question. So we get very often biopsies from the distant metastasis, and we analyze the same way as we analyze the surgical specimen. And so we repeat all the biomarkers.
Very well, thank you. I see here a question that I will answer instead to this question directly, and perhaps you can add a comment later on because it's regarding your project. So the question is, are you using Aiforia CE-IVD algorithm, or are you developing your own? This is the first part of the question, and for that, let me give you the answer. So Professor Anniko, she started with our with Aiforia's model, so the CEI certified model. However, how it happens with every client that we have, whenever we deploy a solution, the solution needs to be calibrated. And that was exactly the focus of Anniko's project. So Anniko's had her own cohort of samples, and we started using the CE-IVD certified model from Aiforia. And with calibration, of course, the model will be adjusted to the reality that Anniko has in her own lab. And when I say reality, we mean different scanners, different procedure of histology, the way the slide is cut, the way the processing is done. So all together needs to be calibrated in order to be sure that the model from Aiforia will answer the final goal for evaluation of HER2. And the question goes further in this part. I will leave it to you, Anniko. Why are you choosing one versus another? Well, maybe I think I just answered this question actually, because calibration is always required independently of the model being certified or not. So let's go for another question. Does the AI algorithm automatically provide a HER2 ultra-low result that the pathologist reviews, or is the HER2 ultra-low result made by the pathologist based on finding positive cells detected by AI?
AI makes it very easy, how I demonstrated on an invasive lobular carcinoma. So you are only looking at the percentage. So for example, in that invasive lobular carcinoma, it showed 4.83 it is under 10%, so it is automatically classified as HER2 ultra low. So therefore, it is very easy to work with this AI because you are just pushing on a button, pressing on a button, and you get a percentage. By eyeballing, it is much more difficult.
Very well, thank you. We have yet another question directly to you, Aniko, which states, Dr. Kovač, what would be the next step to be able to use Aiforia solution in your clinical practice?
It is not me who decided what kind of AI tool we'll be using. So nowadays, in Gothenburg and in our region, we are using a totally different system. So it is the hospital directors who choose a model, not me. But I chose Aiforia for my research, and I even received further grants. So I will be continuing my research, and I continue using Aiforia because we made together with Ruth the annotations. So I can feel that this method is somehow mine because when we were making annotations on several tumors, on very large tumor areas, so that time I learned this method very deeply. So therefore, because it worked for me in my research, I am using it further on.
Thank you for your answer, Aniko. I have here another question that I think I can also answer it live. How do you overcome staining intensities between sites or staining artifacts? That could affect the true HER2 expression. So when a model is taught to the AI, you also need to teach how the environment of the cancer cells look like. So you will not be only teaching the AI how cells look like, you will also teach the AI how the environment looks like, and what for you is considered background. It can be anything that you don't want the AI to identify. So for example, if you have any artifacts, any Pertex bubbles, sometimes you have those dark lines from the lamella on top of the slide. Sometimes you have the tissue wrinkled or folded. So anything that is actual artifact and you don't want to consider as tissue, you will have to teach the AI to recognize that morphology as well. So everything that it's not tissue to be evaluated, then you have to teach as background, okay? All right, let me just go through. We have a lot of questions, and I apologize already if we don't have the time to go all through your questions. I will make sure we'll send the answer to each of the questions privately via email when we share the recording with you, okay? Don't worry. So let me just give a little bit of time to go through the questions that we have. Here is an interesting one. In the surgical specimens, how many blocks do you take when the tumor is huge? In how many do you perform the HER2 staining?
We take quite a big piece from the tumor. If there is heterogeneity, we may take several, but actually, generally, we take only one. For example, if it is totally negative or it is totally HER2 positive, if there is heterogeneity, in that case, it can come into question that take several. Or if I cannot decide whether it is HER2 low or ultra low. So if the scores 1+ is very near to the cutoff point, in that case, yes.
Very well, thank you. Let's have a look here at another interesting question. Yeah, I do see two similar questions here, and I think I'm going to read them both. And that will require an answer from my side. So one question is, coming back to HER2 ultra low, is the cutoff defined in the IFORIA solution? And then there is another question is, does IFORIA use 1% as cutoff here? And this part of the question, I'm actually reading the last part of the whole question, and the whole question will be, I am curious what the rationale was to define the cutoff as below 1% for ultra low null, as Destiny Breast 06 did not specify the lower cutoff. And does IFORIA use 1% of cutoff here? Aniko, I think I will answer this last part myself, and then I will give it to you for you to answer the first part. I'll read it again, okay? All right. So the thing is that within IFORIA, our current model and reporting protocol does not support yet ultra low or low categorizations because the HER2 low requires in situ hybridization amplification results, which is a model that we are working on to be able to make it available for our clients very soon. In the CAP guidelines, HER2 low and ultra low are defined like HER2 low is considered immunohistochemistry score 1+ or 2+. As everyone know, let me go straight to the point when it makes the differentiation between ultra low and 0. So the HER2 low, ultra low, was HER2 immunohistochemistry score of 0 or pattern 0+, with membrane stain that is incomplete and faint, barely perceptible in less or equal to 10% of tumor cells. So basically coming to this answer, we still, as IFORIA, we still cannot give you a correct answer on what the threshold is. In the case of Aniko, it was something that was defined for this project specifically. For IFORIA, this question will come soon when our model will include the HER2 low and ultra low to be included as a CE-IVD certified model, okay? And coming back to the first part of the question, Aniko, for you, what the rationale was to define the cutoff as low 1% for ultra low or null, as the Destiny Breast 06 did not specify the lower cutoff.
Exactly, and I think the key point when you read up that barely perceptible. So therefore, we made this subcategory HER2 null, totally score 0. It is very easy, but when we had a very faint membrane-like staining, which was difficult to percept, or is it really a membrane staining or simply a cytoplasmic discoloration? So those cases we took to this HER2 null category. And which was interesting when we said HER2 null score 0, in spite of that, the AI categorized up and said that there is membrane staining. But for us, it was, for example, totally 0. So the human eye is not always capable so categorically say it is discoloration of the membrane, or it is only an artifact, or this discoloration belongs to the cytoplasma.
Thank you, Aniko. I think we're going to have time for one last question. And then we will have to say goodbye and until next time. So let me try to, well, maybe two questions. I have here one that I can give an answer very quickly. Does IFORIA analysis work with SVS files or only with a specific scanner? So we do work with all kind of scanners. We call ourselves scanner agnostic. So it doesn't really matter which scanner you use, whether it's part of the market or it's just very recently been introduced in the market. We will make sure, if we do not integrate with it yet, we'll make sure to integrate it very soon. So it doesn't really matter which scanner you use. I'm sure i4u will be a good solution for you. Okay. This is, in fact, the end of our session. Thank you all for your questions. A big thank you once again, Dr. Kovac, for an excellent presentation. It was very insightful, and I'm sure all the audience enjoyed it very much. And to all of you in the audience, thank you for joining us today, and I wish you all a great week ahead. Bye-bye.